to arrhythmias, abnormal heart rhythms. So this is the normal ECG, right, that I'm showing you now. It's the normal ECG. How do we read this ECG? How do we read a normal ECG? And because I just to create, there's a stepwise approach, right? On how to read like an ECG. And then so when we talk about tachyarrhythmias, you're gonna we start talking about looking for this, looking for that. It's gonna make sense, right? So I usually, of course, this is not, this is like a crash. We're in an exam, you want to quickly do these things. So it's not like what you're going to do in the clinic when you are rotating on like cardiologists or whatever. So in this case, you just want to focus first on the R's, which will be the rate. Always start with your rate on ECG. I want to know the rate. So, and we know how to estimate rate, which you already did multiple times, 300 about number of what big boxes between two adjacent waves. It could be between the two adjacent RR, two adjacent P waves, two adjacent Q waves, two adjacent T waves, right? Yeah, so you can use any of that. Like in this case, for instance, we have this one R, this one R. How many big boxes we have? 1, 2, 3. And that corresponds to what? 100, right? Beats per minute, correct? So how many big boxes between the waves is equals to normal? Typically what? 3, 2, 5 is normal. So if I count the number of big boxes and it's 3, that's 100. And if it's 5, that's 60, which is within the 60 to 100, right? Heart rate range. Make sense? So any number above 5, I'm dealing with what? A slower heart rate. Any number below 3, I'm dealing with what? A rapid heart rate. Make sense? Okay. So that's that. Quick estimate. Next, check reading. What are you looking at? What are you looking for in reading? 2 things. I'm looking at what? The regularity. And I want to figure out the second thing is what? Is the reading sinus or not? That's like 2 things you're looking for in reading. Is it regular? Is it sinus? And what do we mean by regularity? The space between adjacent waves should be the same, equal. Are the RR waves equidistant? Are the TT waves equidistant? Are the PP waves equidistant? Which means they are occurring at what? Regular interval, which means the SA node is pacing at regular, it's beating at regular interval, right? So that is reading. If the spaces between the adjacent waves are not the same, then you're dealing with what? An irregular reading. Make sense? So that's regularity or irregularity. So this case is very straightforward. This is a regular. If I just by looking at it broadly, the spaces between, right, the arrows the same. About all of them, 3 big boxes, 3, right? So this is regular. So what about sinus? What does sinus reading mean? Sinus reading is a reading that is what? P QRS T. P QRS T. It means that what? P wave must always precede what? QRS. So I'll see P followed by QRS followed by T. P followed by QRS followed by T. If I see QRS before P, I see P after QRS. Right, things like that's not a sinus reading. Does that make sense? So far so good?
Yes, sir.
And this kind of gives an idea, right? That what? It gives an idea of the origin of the pacemaker. The origin, where's the pacemaker? Where's the origin of the beat? It's from the SA node, which kind of makes sense. Remember the way the heart is structured. If I have my ventricles at the top, I have my SA node somewhere here, I have my AV node here. If my beat starts in the SA node, what will be depolarized first? Atria becomes depolarized first, which will be P wave. Then I have a pause in the AV node, and then I'm gonna depolarize each ventricle simultaneously, and that will be my QRS, and then the ventricle will undergo repolarization, which will be the T wave, And the sequence should be like that, which tells me that what the origin of the wave is from the sinus, or the frequency of the origin of the beat is from the sinus node, sinoatrial node, right? SI node, making it a sinus reading, right? So that's super important. Next thing, so rate reading. Now you want to check your waves and intervals. So is the P wave normal? So typically the P wave is usually what it should be. So the P wave, of course, is like with practice, you're gonna get it. P wave should be normal. It should be it should not be as tall, right? And this is what I usually do. I usually look at the P wave compared to T wave. So you can see the P wave in terms of the height, right? It's not as tall as T waves normally. So imagine if I give you somebody that has P wave that's as tall as T wave or even taller, that's abnormal P wave. So it means that the atrial is enlarged, it's thicker, it's bigger. Or the P wave, instead of being a single wave, it's double wave, right? That's also abnormal. Hypertrophy as well, or dilation of the atria. So things like that, that's what you're looking for. And then the PR, look at your PR interval. So the distance from the beginning of the P wave to the beginning of the QRS complex, right? That distance should be what? Usually less than one big box. And remember, a big box is what? One small box is 0.04 seconds. One big box is 0.2 seconds. So my PR interval should be less than one big box, less than 0.2 seconds. If it's more than that, that is a prolonged PR interval, and that tells me that there's something wrong with the AV node, right? There's a greater pulse. Or if the PR interval is too short or absent, so you look at the P and there's no space, no segments between P and the R wave, PRS complex, it means that what the action potential is bypassing the AV node, right? And that would lead to a absent PR interval. So you can see that's in like Parkinson-White syndrome, something like that. So you look for that. Next, look at the QRS complex. QRS complex is very what? About 3 small boxes in width. Less than that. That's about 0.12 seconds, right? So if the QRS complex is wider than 3 small boxes, that's a wide QRS complex. Of course, it can mean that there's something wrong with your bundles, the bundle branches, right? The conduction apparatus of the ventricle. So that we see that. And then PR, QRS, and then you look for your QT interval. QT interval. QT interval, I usually put that about 2 big boxes approximately. So anything longer than that typically means prolonged QT interval. Remember our antiarrhythmics that block potassium channels, that block phase 3, they can do this. This can also put patients that someone can have congenital QT syndrome due to mutation in potassium channels or sodium channels, yeah, things like that. And then you look at your T wave, which should be, you can see the T wave height. T wave height is about half of the QRS complex, right? Imagine if the T wave is taller. That's like peaked T wave. Sometimes the T wave can be flat or inverted, or you won't see it at all, right? Like we saw for ischemia, inverted T wave is too tall. Hyperacute T wave will be hyperkalemia, it could also be ischemia, right? If it's absent or flat, it may be hypokalemia, right? Things like that. So those are going to be things. So basically, you want to identify your waves quickly. Let's say I go through all this step quickly, they all look normal. It's going to be a normal ECG, right? I'm done. Yeah. And there are, of course, some other nuances, right? When it comes to ECG. Some special things like you can look for evidence of hypertrophy. How do I know if the ventricles are undergoing hypertrophy? You're looking at the height of your, remember the V's, especially your V1, the V5, and the V6, right? They are looking at the left ventricle, anterolateral wall of the left ventricle. So if the left ventricle is thicker, I might see what? A very, very deep S wave in V1, deeper than usual, or a very, very tall R wave in V5, V6. Super tall, very, very tall, and then V1 will be very, very deep. If you count the number of small boxes between them, right, and each box is a millimeter, like a small box is like a millimeter, and it's more than 35 millimeter, Basically, it's telling you there's ventricular hypertrophy. Left ventricular hypertrophy. So you had the depth of the S wave in V1 plus the height of the R wave in V5 or V6, and it's at least 35 millimeter, is it 45? I think more than 35 millimeter. Then you're dealing with likely some sort of hypertrophy of the ventricle. Those are going to be some other quick things to check on ECG. And of course, remember our J point, ischemic changes, is elevated or flat, things like that. Yeah, but this is just a quick read on ECG, right? That you can do. Always start your rates, put your reading, look at your waves and intervals. As you're doing that, you're looking at your J point and O. Then you're looking at the height of the P wave, the T wave, the KRS complex, right? The KRS complex to figure out if there's some sort of hypertrophy in the heart or not. All right. Now let's get down to business. Arrhythmias.